Uh, we are having 23 participants.
Hello? Hello?
Yes, please. Yes, Pav. Who is speaking?
You can continue, Dr. Sunny.
Okay, thank you. For today's session, uh, we're having topic discussion in the procure of opiates and how to deliver and selection and rotation. The host is by Sanskriti and co-host by Chap. Uh, the facilitator is Dr. Sudhir. For today, I am doing the part of facilitation as a co-facilitator. Uh, Today's presentation, our speakers are Dr. Ishak and Dr. Krishna, whereas key points learning will be collected by Angela Correa and reviewed by, uh, and the case presentation will be by uh, Parvati Silwar. Timekeeper will be Indu and Dr. Sanskriti. Uh, Regarding this meeting, uh, uh, we'll be taking questions only after the session at the end. Whereas if any queries are there, we can add into the chat where we have dedicated faculty. We will be answering those questions. Uh, I think we are ready to go. Uh, uh, Dr. Ishaq, are you ready? Hello,
Dr. Sunny, we'll start with Dr. Krishna's presentation.
Dr. Krishna, can you share your slides?
Hello, good morning.
Krishna Sagar. He is a consultant oncology and head of the Department of Medical Oncology and Deputy Director at BB Koirala Memorial Cancer Hospital. Please go ahead, sir.
Thank you all, Dr. Sudhir, Dr. Sunny, Megan, Camera, Natasha Show, and all the participants from Nepal, India, and Canada. So today I just opened availability in Nepal. Here, just I'm audible, I am visible. Sunny?
Yes, you are good to go.
Thank you. Thank you. Next. Okay. So this is the oral morphine available in Nepal. We do not have previously the morphine available preparation in Nepal from 2009. With the help of NAPCare and our executive chairman, Dr. Vishnu, he did great role to start the morphine in Nepal. So 2007 onwards, the morphine. Initially, MOR is the name of MOR, MOR, MOR. So this is started from 2009. This is still available here, but the name is changed today. Now the MOR is quite changed as a morphium, not the MOR. So just like the MOR is just similar to name type like death. So the people who are end of life taking MOR. So patient also doesn't feel comfortable. So we request the company to take the name something different. So now is a morphium syrup. So it is available in 60 ml this this container with around 2 mg per ml preparations. And this is a initial 2011 morphine tablet is a sustained release tablet was started and is still available. And at the same time also name is given more 10 tablet, but name again changed now. This is a prolonged release tablet. In 2012 onwards, the morphine 10 PR was available and it will continue. And similarly, at the same time, 2013 prolonged release morphine tablet 30 PR is available. And in 2012, Nepalese Association of Palliative Care develop the protocol for pain management in palliative care, mostly focus for the morphine and the pain management, and how to use the morphine properly, and how to do this both pediatric and adult. The latest protocol for pain management for particular revised, more focused along with the pediatric part. So the recent revised versions of this protocol for pain management in palliative care has both contain adult and pediatrics. And this is a company we requested, National Healthcare Pharmaceutical Company, and they are very happy to help us. So nowadays, this company have the formulation just like fentanyl 50 mcg per ml injection available. There are no patches available in Nepal, manufactured in Nepal, but we can get easily from the India and cross border the fentanyl patches. So it is not that difficult getting the fentanyl patch. But Nepalese preparation is only the injection 2 ml ampoule. Similarly, the morphium 10 mg, morphium 10 is the tablet. Both immediate release and sustained release tablet available in the 1:10 strips. And similarly, morphine syrup 10 mg per ml syrup is available 60 ml package. Similarly, morphium injection 1 ml ampoule, the 10 mg per ml is available, and morphine 30 mg PR and RPGC. Even pethidine is also available, manufactured by the same company, National Healthcare Pharmaceutical Company, Nepal. So uh, just this is the same slide. I am copied from Dr. Vishnu's slide. So this is the situation in 2002. Morphine consumption in Nepal, India, in other things is quite low, and in around 2005, 2 and 2005 reports. But with the initiation of the morphine production and Nepalese Association palliative care, it helped a lot, advocacy for the morphine preparation, distribution, and other things. So this is in around 2012. The Nepalese have almost highest consumption in the per capita wise in Nepal. This is a study done in Pain and Policy Study Fellowship, Dr. Vishnu and et al. So this is the thing, and still we can have them. We do not have much problem with the getting morphine. So in this slide also, this is we can see morphine is use and consumption as compared to others. So morphine is now main opioid analgesics, very easily available in Nepal. The Nepalese Association of Palliative Care is advocating, and especially Dr. Vishnu leading the lead in all the production and advocacy. And now we have the big team in Nepalese Palliative Care who has advocating for the more production. But we do have the difficulties to get morphine in periphery in the Kathmandu major hospitals and periphery in Chittagong and other area, Dharan, some of the Pokhara, we can get the morphine, but it is not. Sometimes the institution do not have uh, interest, or maybe there may be short supply and nobody follow it. So sometimes most of the people beyond Kathmandu come to Chittagong to take the morphine. So we again talking with the respective institutions to make the morphine available, and even we talk with the company to deliver that. So Saja pharmacy, Saja Swasthya Seva is distribute the medicine. So we used to talk with them to have their all brands morphine available. These are the government pharmaceuticals distributors who can have access in every corner of the hospital of the nation. So if the SADA buy and deliver morphine, it can be easily reached to the most of the remote area, even the major hospitals and remote all the 7 provinces of the Nepal. So sometimes, but we do have the difficulties of morphine where there is a palliative care setup, and oncologists and who are used to use the morphine, that is very comfortable to use it. But some of the area, even the center where they are oncologists, other things, but the morphine preparation, morphine rotation, and the exact dose sometimes is varies. Varies may not be not varies. It may not be exactly. They just think that just like somebody prescribe morphine as a single dose, sometimes SOS, sometimes BD. Just so it is not much. They use the morphine, but not properly. So we are advocating also for that, and we are conducting regular training for the healthcare worker throughout the Nepal. Under the Nepalese palliative care, we are taking the lead with the NSTC, Nepalese Health Training Center. So every year, 4 to 5 batches of 16 people we are conducting. This year also, after COVID, we have already conducted one in the Chittagong, and we are going to have the next one in Kathmandu soon. So this year also we are training many healthcare workers, and we are more focusing what are the morphine available in Nepal, and how we have to use it, how we have to purpose when there is a problem, how we can solve it. So even in that classes also we used to take morphine and other things. But the problem in Nepal is the doctors is required, and Nepal Medical Council license and registered doctors is required for the precision, so which may not be feasible in the remote area always. And even they give the single precision, written precision for the morphine, and the pharmaceutical, they used to take the original precision and they delivered. So we cannot uh, prescribe for the long time, maybe 5 to 7 days in general hospital. In cancer hospital, we are giving on our request maybe 15 days up to the 1 month, but beyond that we cannot even not available, not prescribed. So when we are prescribing more also, even they used to give the less dose, so patient have to travel all the way to the center where is it available. So this is the some of the obstacles still we have to
Dr. Krishna, we can't hear you.
Dr. Sagar, we can't hear you.
I think he has got some internet issues. We can proceed forward, Dr. Sunny.
I think there is problem with this internet. Let's move forward. Before moving for the another presentation, we have Dr. Megan to make some announcement. Dr. Megan.
Thank you. So very nice evening to everybody. And I just want to say that if you participated in part 1 of the ECHO, we're interested to hear a little bit about your experiences and how it has changed your practice. So we are going to ask if you would volunteer to have an interview so we can ask a few questions. It's all anonymous for research. Just so we understand better, like how did the ECHO help and what is good about it and how can we make it better in the future. So you can just message me if you're willing to participate in an interview. It's about 20-minute interviews. Thank you. Maybe we can go to Ishak if we've lost Dr. Krishna.
Dr. Megan, that would be a Zoom interview.
Definitely. I wish I could be in Nepal, but they won't let me leave Canada right now.
We'll have you some days later then.
Definitely.
I think Dr. Krishna Sagar is back.
I think we can proceed with Mohammad Isaaq's presentation. We are already late, running late.
Yeah, sorry, I am disconnected and getting connected. That's the utmost mine. So Ishak can take now the rest of the class.
Ishak, would you like
Thank
to
you.
share slide? Or we should share?
I think Dr. Sanskriti will be sharing the slides.
Okay, Sanskriti, please could you share the slides? Go ahead, man.
গ্রহণ করছে আপনি আমাকে ব্যাখ্যা নাকি
त्यसमा कनेक्ट भएन है
Dr. Sudhir, I'm not able to see the slides. Good morning, everyone. My name is Ishak, and I'll be talking about opioid rotation today, and how we can like select opioids as well. So next slide, please. So scope of discussion would be what is opioid rotation or switching, reasons and problems associated with opioid switching, and equianalgesia and how to switch. Next slide, please. So opioid rotation is the process of switching from one opioid to another or changing the route of administration of an opioid to improve the response to analgesic therapy or to reduce any unwanted side effects. Next slide, please. So what are the reasons for switching or opioid rotation? One can be that whatever medication we are using, whatever opioid we are using, it has having severe adverse effects which are not tolerable. For example, if you are using morphine and if there is severe side effects such as neurotoxicity, myoclonus, delirium, hallucination. So whenever those side effects are there, we want to try to switch the opioid to a better acceptable opioid. And if there is a development of tolerance, so tolerance is something that develops over a period of time. In few occasions, what happens is even if when we are giving a particular dose of opioid initially, which was providing pain relief to the patient, and later on is not providing pain relief, and we keep on increasing it, and there is development of tolerance for that opioid, and if it's not working, then we think of switching to another alternative opioid. One another thing is poor response to first line of opioids, which I have told, like whenever we start an opioid, we look for the response. And if you're not getting a good response with a particular opioid, we think of switching to another opioid. And one more reason to like shift would be need for alternative drug administration routes. For example, few patients might not be able to take the oral formulation of morphine, which is the first route which we use generally in almost all patients. And when the patient is not able to swallow, or whenever the patient is not able to tolerate orally, we need to think of like giving either subcutaneous route or IV route, or we need to change the opioid altogether for a transdermal route, maybe such as fentanyl. So that's one more reason why we would switch another opioid to. And when we want to decrease the treatment cost, normally fentanyl as such costs quite a lot of amount of money. And there are medications, alternative medications, which are very cheaply available. For example, morphine, methadone, these are cheaply available drugs. So when we want to decrease the treatment cost, if a patient is coming from far off and can't procure those medicine as well, we tend to like switch to a medication that is easily available and it is costing less. And there is one more entity known as opioid-induced hyperalgesia. So opioids are normally used for like pain relief, but when opioids can paradoxically also exacerbate pain. So it can be seen in acute or chronic pain scenarios. This results from sustained sensitization of nervous system in which excitatory neurotransmitters and NMDA receptor channel complex play an important role. So whenever there is a patient whom we have started opioids initially responding well, later on suddenly with increasing uh, pain, we tend to increase the dose, and we see that even with increasing dose, the patient is not having any kind of relief. Then we need to think about this entity known as opioid-induced hyperalgesia, in which we need to decrease the main opioid which we are giving and to shift to another opioid so as to decrease the complex phenomenon that's going on. So one more reason why we would want to switch is non-acceptance of drug by the patient. Normally in our scenario, we haven't seen like this playing a much major role, but in few countries, we might have patients who don't want to use a particular uh, form of opioid. So that can also be a reason for why we would want to switch an opioid. Next slide, please. So just few examples. For example, if there is poor adherence to morphine oral or methadone oral or any medication which we are giving orally, if they're not adhering, we can think of using transdermal fentanyl when there is significant decline in patient's renal function. So um, morphine is one drug which we use a lot, and it is excreted via the renal system. So whenever there is significant decline in renal function, maybe if the creat is very high, maybe more than 2.5, and there is a component of renal failure, we tend to shift from morphine to methadone or a transdermal fentanyl patch. When there is inadequate pain relief, like we told, when there is inadequate pain relief, we would tend to switch to another opioid to provide good analgesia. And when there are intolerable side effects, for example, last session we talked about constipation, and Dr. Megan brought up the point that we can shift the child on fentanyl as well, which is uh, which causes less constipation when compared to morphine. And lastly, opioid-induced hyperalgesia, like I said, that whenever there is this clinical entity, we have to come down on the parent opioid and shift to another opioid. Next slide, please. So what can be the problems with rotation? So using incorrect conversion dose is one thing that can uh, be a problematic thing, because various opioids have various strengths. For example, morphine to fentanyl, if we take the strength, fentanyl is 100 times more powerful than morphine if you are taking the parental route. And if you are using tramadol, we normally don't use tramadol in less than 12 years of children. But if you're using tramadol, morphine is 6 times powerful to tramadol. So we need to know the conversion strengths. And another problem is difficult dose titration. So when we are comfortable with one particular opioid and we shift to another opioid, we tend to have difficulty with dose titration as well. For example, if a patient is on morphine and we have shifted on fentanyl, and if the patient is having breakthrough pains, we tend to give either morphine parenterally or orally. So we need to have this proper plan of how we dose titrate the opioids. And one more problem is inadequate use of adjuvants. So regarding this, we have like previously talked about various use of adjuvant drugs. So when we are not able to use adjuvants properly also, this is one reason that causes problem with rotation. Next slide, please. So this slide is on equianalgesia. So equianalgesia is nothing but giving a particular amount of pain relief by two different sets of opioids. So it can be a particular dose of morphine and fentanyl, providing a proper analgesia So that dose of opioid is nothing but a equianalgesic dose. So it is defined as the dose at which two opioids at steady state provide approximately the same pain relief. So here we have different opioids, and on the right hand side we have what is the equianalgesic dose. So normally we are not using, I know Nepal doesn't have, in Nepal and India doesn't have so many different formulations, but majorly I just wanted to show that morphine, when we are using 30 mg of morphine, the equianalgesic dose of fentanyl is around 12.5 mcg per hour. And for methadone, it varies actually. So it depends on the amount of total morphine. So I won't go into detail of methadone here. Next slide, please. So now I'll be just bringing up few scenarios and how to switch. For example, Kiran is a 7-year-old boy with neuroblastoma, reporting severe pain of 8 by 10 on the left side of the chest, radiating to the back. He started on oral morphine of 5 mg Q4H along with 5 mg breakthrough doses. Pain was well controlled, and after that, mother tend to skip few doses of morphine since the child was pain free, and next day child has reported severe pain 10 by 10. So I'll give you just 10 seconds to think what you would do. A child has come with severe pain now, who's has been used opioid prior, he's not opioid naive. So what can be done? Next slide, please. So since the child has come with severe pain, we would want to break the cycle of pain immediately. So what we can do is we can give a stat dose of parenteral opioid. It can be either subcutaneous or IV morphine. Since the child was already on 5 mg of morphine, Q4H, since we know that morphine, the strength of morphine, oral morphine to subcutaneous or IV is 1:3, we can go with a dose of 1.5 to 2 mg of morphine. If the child is having IV line, you can give morphine slowly through IV itself, or if you have a subcutaneous line, you can give subcutaneous 1.5 mg to 2 mg. So the same child again, after taking 2 cycles of chemotherapy, he's right now on regular doses of morphine, and he has developed severe mucositis and vomiting. So he's not able to tolerate the oral medication. Mother is concerned regarding not being able to give his pain medication. So what can be done here in this scenario? Again, I'll give you 10 seconds. Just think what we can do since the child is not able to take orally, not able to tolerate the medication. Next slide, please. So here we would want to switch to a fentanyl patch. So fentanyl patch is available as transdermal patch in India, apart from the injectable form. So since Kiran has already been using 30 mg of morphine 24 hourly, when we convert it to mcg, it comes around 30,000 mcg. And like I have told, like we know that morphine to fentanyl, the strength is 1:100. So we divide the dose by 100 to get the dose of fentanyl that need to be put for 24 hours. So when we divide by 100, we get 300 mcg over 24 hours. And fentanyl patches are available in per hour doses. So for a child who's on 30 mg of morphine can be given a fentanyl patch of 12.5 mcg per hour. So we can use this. And since it's not able to tolerate orally, we can also give a breakthrough dose of 1.5 to 2 mg of morphine, either subcutaneous or IV. So this is regarding this scenario. Next slide, please. So the third scenario was about Kiran is now able to tolerate orally. He's been shifted to oral morphine again from a transdermal patch. and is due for discharge in 2 days, mother is not able to give the fourth hourly doses. He's comfortable with 10 mg now, so we have gone a higher dose. Right now, he's taking 10 mg Q4H of morphine and is taking 1 to 2 breakthrough doses. So, what can be done? So, in this scenario, since the child is already able to take orally, so we calculate the total dose of morphine per day, which comes around 60 mg. And we have this preparation of sustained release, which can be given 2 times a day. So we divide it by 2 and we get 30 mg BD dose of morphine. So we can shift him to sustained release morphine since mother is not able to give regular repeated doses. And we can have the breakthrough dose of 10 mg IR. It is the same dose of what the regular dose of morphine which you are giving Q4H. So with this, I complete the scenarios here. I didn't want to go deep into methadone discussion because very few, like Dr. Krishna told me that a lot of centers don't have methadone. But just to tell few points is methadone is a very good, strong opioid. It acts by multiple mechanisms, such as it acts on mu, kappa, delta receptors. It is an opioid agonist, and it also acts on the NMD antagonist. It acts as an NMD antagonist as well. It also works on 5-HT noradrenaline pathway. So whenever we have morphine and we want to shift to methadone, what we do is we calculate the whole dose of morphine that is being taken, and we use that dose in the conversion ratio chart. For example, here you can find that, for example, I'll just consider Kiran itself in this situation. So Kiran is being given like around 60 mg now, and we want to convert it to methadone. What we need to do is we have to use the conversion ratio of morphine to methadone in less than 100 mg bracket. So it is 3:1. So he's using 60 mg. So the dose of methadone after the conversion would come as 20. What we need to also remember is there is something known as cross tolerance, which we take as 25 to 50%. So we half the dose because of cross tolerance. What we do, we take half the dose of whatever calculated dose we have got. So it will be 10 mg now. So 10 mg, we can give it as a single day switch or a 3-day switch. So a single day switch would be to shift from morphine to methadone on the same day. But if we want to go on a 3-day switch, I am comfortable with a 3-day switch uh, in here in my setup. So 3-day switch, what we do is we decrease the dose of morphine by 1/3. For example, since he's using 60 mg, we reduce it by 1/3. That is, we reduce 20 mg of morphine and we add 1/3 dose of methadone of what we thought. For example, in this child, we got 10 mg of methadone. So we add 3.5 mg of methadone on the first day. On second day, we decrease 2/3 of morphine total dose. So we come down to 20 mg on second day, and we increase methadone accordingly. We give around 6.5 mg of methadone. We can give it 3 times a day. And on the last day, we completely shift to methadone. What we need to remember is we can use methadone both for breakthrough pain as well as for the baseline pain relief, or we can use morphine as well. So this was regarding methadone. I didn't want to go deeply into methadone. There are few questions in the chat regarding how frequently, like, is methadone available freely? It is available in our setup, and quite a few setups which are in touch with us use methadone as well. So with this, I complete my presentation. Thank you for patiently listening. Any questions or anything?
Dr. Isaac, well, that's a nice presentation. We don't have more subject opiates available at every center, so it's a bit difficult. with switching. I think Dr. Sudhir could have any ideas or experience with switching and selection of drugs, the drugs. Dr. Sudhir.
Yeah, and thank you, Dr. Sunny. Yeah, regarding the availability of opiates, we only have morphine at present, so which is available, and methadone. I think they are using it from detoxification centers only, exclusively for rehab centers only. It is not easily available for pain management in our center and all over Nepal also. And fentanyl patches, uh, they are not available regularly, but due to the cross border, they can be brought by some patient by themselves. And fentanyl injection though is available. So with this, I think we have very less options for opioid rotation, and maybe Napier can work more to bring the other options of method of opioids in Nepal. So maybe we can request Dr. Vishnu and Dr. Krishna so that we can have other forms of opioids also in near future. Thank you, Dr. Sani.
Thank you, Dr. Sudhir. I think Dr. Krishnadat is not with us today. Otherwise, you would have elaborate more on these things. Any thoughts on this, Dr. Krishna Sagar?
Thank you, Sunny. Yeah, we do have codeine. We do have the codeine preparation available, widely used as well. Most of the in adult, but in pediatric we rarely used. So sometimes the metabolism and doesn't do almost one third do not have the good metabolism. So we available, but we rarely use. But sometime when we adjust with some other drug, it works. Mostly in adolescent children, maybe sarcoma we use. Methadone is not available. Morphine, I already said the morphine preparation is available. So, yeah, only the distribution center they use methadone, but very rarely use in the palliative setup. So, if we can have some Nepalese preparation, it is not Nepalese preparation. So maybe we can use in the palliative setting and in the life care. The issues is central hospital where a doctor is available. There we can prescribe the morphine. The Saja health center deliver most of the area, even morphine all over the Nepal. So if we can connect with the Saja and some of the doctors over there, maybe we can easily reach out to the patients. But it still is not connecting well in the periphery. So we are at the NAPCare, we are working for that, and the Nepalese palliative strategy planning, which we have NAPCare take the lead in 2016 and hand over government. They are accepted. So we are still from last week also I talked with the ministry and they are quite happy to deliver, but they don't have the exact mechanism how they have to deliver it. So it's on the process. So certainly we can make the opioid available, especially morphine available to the local levels, because now the government started every we do have a 753 local governments, and they have the started the hospitals where doctors should be there, so they can prescribe the morphine, and then other people around can reach out easily opioids and morphine. So that's so far in Nepal. Yeah.
Thank you, Dr. Krishna. Spandana ma'am, could you please say what is the situation in India and what are the availability so that our NAPCAT could assess any availability from we could bring in Nepal as well. Spandana ma'am.
The one thing I just want to say is in India, the availability is very, very varied. The north of India has a lot of issues in stocking and even sometimes procuring morphine and storing it. Whereas I think in the south, it is much more easier due to various regional and cultural issues. So at our center, which is one of the biggest regional cancer centers, we have preparation of morphine 10 mg, 20 mg, 30 mg, and 60 mg, immediate release and also sustained release. We have injection morphine, 1 ml 10 mg and 1 ml 15 mg. Sadly, we do not have syrup morphine. It is not available in any part of India. So we do not have a morphine preparation. We are trying to talk and somehow get it done, but it hasn't been done yet. So we use a diluted version of oral morphine or injectable morphine for smaller doses. If I have to give 0.2 mg, 0.3 mg for a newborn, right now what we are doing is we are diluting it and giving it. And fentanyl, we have transdermal and injectable just like you. Transdermal patches, we have 12.5, 25, 50, 75, and even 100. As Dr. Ishak has said, it is quite costly, but we do get some of these strengths at our government hospital for free of cost. So the government bears the cost, procures it, and we give it to the patients free of cost. So but we are mindful that it is a limited resource, and we use it only when it is very, very required. And methadone, we have 1 tablet 5 mg strength, and also we have syrup 1 ml 5 mg. Again, we use syrup sometimes in adults when we are short on tablets, but we do use a lot of, I don't know if there are any adult palliative care people on the group. We use it for head and neck cancers and cervical cancers because the pain is much more complex. It could be inflammatory, a nerve involvement, bone involvement, and also uh, the soft tissue pain. Whereas in pediatrics, I have used it in some infiltrating even germ cell tumors, but mostly I have used it in bone tumors, osteo and living sarcomas with very good relief. Sometimes the children have stayed on methadone for quite few months, for years also. We had a child with hepatocellular carcinoma who stayed on it for quite a few months. So it is quite safe methadone, but again, we need a lot of practice. So these are my thoughts on opioids in India.
Dr. Sunny, you are not audible. You have
Thank
to
you, ma'am.
unmute.
Now, moving on with the case presentation. Um, we have our case presenter, uh, Parvati Silva. She is a senior staff nurse and second in charge of pediatric oncology in PP Koirala Memorial Cancer Hospital. Uh, please go ahead, ma'am. We are sharing slide for you.
Good morning, everyone. Welcome in my presentation. Me, Parvati Silva, Senior Staff Nurse, BP Koirala Memorial Cancer Hospital, Bharpur, Chittagong. Thank you, Dr. Sudhir. Key question for the case presentation. Role of the nurses for pain management in pediatric palliative care. Symptom management in the
It is
adolescent.
not visible. Sonny, the
Sorry.
slide is not visible. Can you just check it?
It's okay.
Slides is not visible. Not yet.
Slide
It's
is not
okay.
visible.
Hello.
Now,
Not
It's
yet.
okay. It's okay.
Sonny, just try it. Start. Yes. Yes, now it is. Yeah.
Thank you. Key question for the case presentation, role of the nurses for pain management in pediatric palliative care, symptom management of the adolescent, multidisciplinary approach for management of complex recession, psychological counseling for the adolescent. What can be done more for her treatment? Patient detail. 16 years female child has a diagnosis at June 22. Other diagnosis is systematic lupus erythematosus. Working with a child in pain is difficult and challenging, especially when the child cannot explain what they are feeling. Each child has their own story to tell. This is a similar story of a child suffering from AML, non-M3, coming from rural setting, from a lower middle class family that takes around 2 to 3 days to reach this hospital. Moreover, she is an orphanage whose father died from hypertension stroke 4 years ago, and mother died after being diagnosed with cancer. All the treatment that are being done by the help of charity. 60,000 $60,000 has been taken by the charity for her treatment. However, it is unimaginable about the pain and the child is bearing and going through. Treatment and significant investigation. Blood investigation SB slightly low range anemia, platelet count, pancytopenia, WBC is normal, biochemistry, hypoglycemia, alkaline phosphate is higher range, sodium hyponatremia, other are normal. Bone marrow aspiration, hypocellular marrow with 82% blast, peripheral blood smear shows pancytopenia, CSF cytology shows negative for malignancy, flow cytometry shows AML panel positive. Past medical history, normal vaginal delivery at home, normal growth and development with the menarche at 15 years, no any significant past medical and surgical illness. Holistic assessment, physical assessment, pallor, petachy, and purpura, psychological assessment, fear to loss here, emotional worried about to fear of death, spiritual seeking different option against the bad evil, familial middle class family, good family support, especially brother and sister, social fear of social isolation, holistic assessment, pain and symptom including relevant treatment, difficulty in walking 4 to 5 months and fever from last 15 days, associated with whole body pain and vomiting, gum bleeding, weakness, headache and confusion also. On the examination, fever 104°F, pallor, abdominal distension, pain score at by 10, petachy purpura on the skin, nodule on the neck. Investigation, hematological, biochemical, MRI, LP, CSF analysis, microbiological, blood and urine CS stool, radiological, chest X-ray, CT scan, etc. Treatment, IV antibiotics, IV fluids, transfusion, Paxil, platelet, analgesic, tab codopar, opioid tab morphine, anxiolytic, tab lorazepam, antidepressant, tab amitriptyline, etc. Injection, transistor for bleeding control, anti-cancer drug, AML non-M3 protocol is receiving. Holistic assessment, psychological and family concern, persistent headache, her older sister is healthy, her father was died from hypertension 4 years ago, I already told, and mother was died from unknown cause after her cancer diagnosis. There is a fear in family to lose her from cancer. Parents were seeking her different medical opinion if she could be cured from various hospitals, support from both parental and maternal side, especially her brother and sister. Holistic assessment, spiritual concern. Her brother and sister worried about why all this happened to her. Brother said that cannot do anything for her. They are seeking different opinion against bad evil which they thought of causing cancer to her. Holistic assessment, communication. We encourage her sister and brother to spend time with her, which help to ventilate her feelings and worries. We make several appointments for our personal counseling about disease, treatment, and its outcome. We encourage for her positive thinking and expression her feelings. Parental and career counseling was taken for multiple times. Holistic assessment in collaboration and partnership. Pediatric oncology team She is in remission, and in spite of good dosage of paracetamol, other NSAID, along with anxiolytic, her condition not much improved. Sometimes, hospice and palliative care team, her pain management, and her persistent headache, joint pain, abdominal pain, morphine and adjuvant added. Radiologist MRI of the brain was done, and it's normal without any abnormalities. Pathologist CSF analysis is normal. Dietitian for her dietary rehabilitation, physiotherapist for her pain and weakness on her limbs, social worker for her family support and counseling, religious healer, they seek multiple time faith healers for her quick recovery. Psychiatric antidepressant was added and her condition was improved dramatically. Nursing care. We encourage them to maintain personal hygiene, perineal hygiene, seize bath, oral care. We encourage them good dietary supplement with high protein diet. Perform the multiple meeting with doctors, nurses, hospice and palliative team, dietitian, physiotherapist, radiologist team. Educate on sign and symptom of infection and neutropenia management, patient and family counseling. Estimate price, hospital stay, duration of the treatment, side effect of the chemotherapy, handling of the patient body waste, urine and stool and vomit, follow-up care and home care management, format of self-care and independence. Summary of the case: 16 years female, child with AML, non-M3. Her disease is in remission, but her symptom control needed. Multiple team effort as well as diversional therapy also. Now family is cooperative with the hospital staff and happy with her improving condition. Nursing team provided support and help parents how to provide care for her as well as self-care, prevent from depression, understand child psychology. Play and diversional therapy is good for pain management, easily adjustable in new environment. Key question. Is the nursing care is adequate for pain management? Is the multiple team collaboration is adequate? If not, what could be done for her better recovery? Is the symptom control is acceptable? Where it took almost a month to come to conclusion. What should we do where multiple disciplinaries are not available at single setting? What extra measures should be taken to prevent her from depression? Thank you.
Thank you, Ms. Lord, for such a nice presentation and also highlighting the nursing care importance. I think for the care about nursing, cameraman would elaborate anything that could have been done more for the nurse. Cameraman.
Well, I'm just so impressed by the wholesome care that was provided and looking at the amazing work that was done. I think that a few things that were touched upon in terms of just providing support during suffering is really amazing. One of the questions that I noted was, how do you get the team together? How do you have communication be sort of across the board, and how do we manage that? And I do wonder if there is kind of a main communicator that could be helpful in that. So identifying someone that is most connected with the family on a day-to-day basis to bring that information back to the team so that the family and the child doesn't have to repeat all the time. But I really enjoyed seeing that play was incorporated and really a lot of attention to suffering, not just the pain, but actually the isolation and being in hospital.
Thank you, Kamara, for your good comment. Parvati sister itself, she is a main communicator with the child. Seconds in charge. So she used to expend most of the time with play, diversion, therapy, even the counsel the parents. So she's taking the leads. And we do have one survival doing volunteer in the ward. So sometimes almost peer group, almost same, she's around 17, 18 and 19. So she used to talk with her, and sometimes she bring up our issue to me and our team. So we discuss separately and address it. So she has quite a complicated case, connective tissue disorder, not diagnosed since long time. We also very difficult to, we are more worried about the her face is disfigures, whole body lesion, something like that. So once you are diagnosis, we think there is something others disease also. That's how we diagnose connective tissue disorder. Both ANA, dsDNA is quite high, and we started along with the low dose steroid. So she's doing well. She's quite happy. She is making lots of gift to the staff also. She's in spite of the play and other things, she's knitting the just like caps and gloves, something like that. And she also teaching to others. So she's, and even she studies, she's continue her study, and even what when she is free, she's doing her work. So basically this goes whole team, and especially Parvati sisters who is leading on the counseling part and other things. So she should that. Thank you, Parvati sister, and happy camera for your picking up the points. And she's very good to counseling, and even sometimes she had done psychology and then diversion therapy also sometimes she is to do herself. Thank you.
Dr. Krishna. Dr. Peter, would you like to add anything?
It's okay, that's much. And but we do have much less, we can do much, but diagnosis wise and support wise may not be adequate, because she had some other need, some other interest. So we cannot fulfill for that. The familially have no father, no parent, only the brother sister helping us. If there is some social counselor, social volunteers, still more we can support back to her home. That is the main challenge for us. When she's quite adapted in the hospitals, quite happy, but we are near the discharge. So how she will taken as a family when she is going to back home, or when the community will take her, because she has a multiple disease, and there is still taboo in the some of the village, and she's quite from far. So that is the issues, how we have to rehabilitate her in back to her home. That's the issue. Thank you.
The presentation was quite nice, and it looks like she was getting a lot of support also. But with any patient, child or adult, we have to know how the child is taking it. Like, you are making the child more active, you're encouraging her to take care of herself, hygiene and all that. But whatever is possible, getting the child more engaged, because just doing something will keep her mind more occupied and understand what's going on in her head, because every child or every individual will perceive the same situation differently. And then go forward for rehabilitation and taking care of what's going on in her mind and managing those thoughts and being a little more realistic about it with her, helping her rationalize, because everything you think might not be correct and it might be very troubling to the individual. Thank you.
I was just going to add, when you talk about going home and all that uncertainty about going home, that's very, very hard for the family and for the child. My advice around going home is to plan for hope. So plan that things go well and let the family know we hope all of this goes well. To plan for things not going as well, and helping family anticipate what might come up, and also helping her anticipate what do you understand might happen in the next weeks and months, and how can we help you be prepared for that. So it's using your clinical brain about what you know about the illness, and then it's also using your compassionate heart to help plan and support families to leave the hospital if that's where they're going to go.
Thank you, Kamara, for your, yeah, we will try our best.
Thank you, Camera, and thank you, Dr. Krishna. Any other questions? Any other thoughts? Dr. Peter, would you like to add anything?
I just want to echo what Kamara said about how impressive the holistic care that she received was. And if I were to comment a little bit about the medications, it sounds like things were rationalized a little bit after she, from when she was admitted. It seemed like she was on codeine and Tylenol initially and morphine. And I assume that she was switched to just morphine only, as we were discussing before, because of the concerns about codeine. Amitriptyline in her case was a good choice for the antidepressant because it's also an adjunct for her pain and could be helpful for her pain in the long run as well.
Thank you, Dr. Peter. Any more questions? Megan, would you like to put some views?
Yeah, just to say that if you have patients on codeine, switch them to morphine. You should not keep the patients on codeine. It's not safe for children. We do not recommend it. Codeine is metabolized to morphine. So just go for morphine because then you don't have to worry about the metabolism issue, like you mentioned earlier in the presentation, that codeine, some children metabolize it rapidly and some children metabolize it very poorly. And you don't know which are in which group. So you should just go for oral morphine, and you have good options. You have the liquid and you have the tablets. So you should really just use that. And I know I've talked about the switching and, you know, what are the options, what's available, and it's limited to morphine. It's the same in Bangladesh. We just have morphine. And my experience is you can manage the vast majority of the patients. There are some that it's very, very challenging, but for a lot of patients, you can make them a lot more comfortable. So I think sometimes it's good to focus on, you know, it's a very foundation. It's the bottom of your pyramid where the majority of your patients are going to be managed with morphine, and getting that use of morphine to be widespread for children with advanced cancer in Nepal is going to improve the lives of lots of children.
Thank you, Megha, for having such a touch. I think we'll be using more of the morphine for pain relief now on. If there are any more queries, we can continue with the chats. I think for today, we'll be ending the session now. Thank you.
Thank you, everyone.
Thank
Bye-bye.
you.
Thank you. Bye-bye.